Today we're talking about the coarctation of aorta. So here I would like to draw a simple 2D structure of the heart. So we are drawing 4 chambers over here. These are the valves. So this is the right atrium, right ventricle, left atrium, and also the left ventricle. So we know this is the pulmonary artery and this is the aorta. So when the baby is first born, it is born with a ductus arteriosus which connects the pulmonary artery to the aorta. Okay, and we have all these branches, 3 branches over here, which supplies the upper limb. So this goes down, the aorta becomes a descending artery and supplies the lower limb. So when we talk about the coarctation, we are talking about narrowing of the aorta. So normally it narrows before the ductus arteriosus, so it's here. Before the blood can even go down to the lower limb, it's already narrowed. But the blood flow over here is still okay. The vessels are still intact, it's not narrowed. So when we talk about this narrowing, we see that there is increase of pressure and increase of load. There's a blood flow here, and then it gets gets a lot over here, and then blood flow here is somewhat lesser comparatively to here. So when we see that there is increase of pressure and load in the upper limb comparatively to the lower limb where there is decrease of pressure and decrease of load, what are the signs and symptoms that we can see in the patient? So first thing commonly we see is chest pain. Why chest pain? It's because of hypoxia, because of left ventricular hypertrophy, as there is increase of load. So there's a lot of blood over here, and thus the left ventricle works really hard to try to pump that extra load to the rest of the body, but it's having a tough time because there is a narrowing here at the aorta. So there's left ventricular hypertrophy, and this causes an increase of oxygen demand and thus causes chest pain. Secondly, we see intermittent claudication. Now this is apparently quite common as well. Intermittent claudication at the lower limb. So that's because there is hypoperfusion, less oxygen supply towards the lower limb, and thus child feel painful at the legs if the child does physical activities. Also, not to forget hypertension. If there's any unexplained hypertension and whatnot due to the increase of pressure and also the increase in load. And also, we see that in hypertension, why is that so? It's because there is reduced perfusion to the kidney, and so we see that the RAS systems are activated. So that is how the hypertension happens if the patient comes with unexplained hypertension. Fourthly, rarely also, we see that there is intracranial bleed or stroke. Now, we can see that there can be Barrett's aneurysm in the elder child, and causes bleeding and whatnot, because it's due to the upper limb supply where there's higher pressure and higher load. So these are the pathogenesis. So now we want to see the sign. What are the signs you want to pick up? I think the most important one is the femoral pulse, and anything got to do with femoral pulse. And also we see there the radiofemoral delay. Okay, so in femoral pulse, we see in newborn examination, if we find that it's absent, we must act now. Now why? Is because this indicates severe coarctation of aorta, or you can understand it as interrupted aortic arch. So when there's absence, so we see that the lower limb supply is like completely obliterated. Because the narrowing is too severe that the blood going down to the lower limb is very, very little. So why you want to act now is because the collaterals haven't formed yet. The collaterals at lower limb haven't formed yet. So it haven't formed. So you really need to act now and move onwards towards surgery. That's for the treatment. Now if you feel the femoral pulse during the newborn examination to be weak, so this might indicate mild to moderate coarc. So there's mild to moderate narrowing, right? So in around infants, maybe 1 year old or even elder children, if you find that there's radiofemoral delay, so why is that so? It's because there is collaterals already formed at 6 to 8 months. There's a delay because we have higher pressure in upper limb and lower pressure in the lower limb. So this is the main concepts of coarctation of aorta. Now to add on the severe, one of the complications that we also need to know is metabolic acidosis. There are two mechanisms that we can go about it to explain about metabolic acidosis. Firstly, is because of the hypoxia at the lower limb. So this causes having anaerobic metabolism, which produces lactic acid acidosis due to the underperfusion of the lower limb. The second explanation is the same explanation as the hypertension, is where there is lower perfusion to the kidneys, to the lower limbs, and thus the kidneys can't get rid of acids. So these are the two important ways to explain how does a child gets metabolic acidosis. Now, how are we going to investigate? Also, to add on to the signs, sometimes you might also get incidental heart murmur. So this heart murmur is a systolic murmur at the infrascapular area of the back, or infraclavicular at the upper left sternal edge. So this could indicate coarc as well. So when you move on to the investigations, how we would like to investigate? Let you investigate by doing three things: chest X-ray, ECG, and also the echocardiogram. So for chest X-ray, now we want to do this in newborn if it's critical. Then we can see cardiomegaly due to heart failure because of the left ventricle hypertrophy, needs to pump a lot, and thus there's cardiac failure. And yeah, that's what we want to see also. And for elder children, we want to do a chest X-ray to see rib notching. Now, what is rib notching? What is it? So we draw back to the anatomy of the aorta. Now these are the three branches that leads to the upper limb, and we're drawing the descending artery over here. And also we're talking about the thoracic artery over here, and we're talking about the anterior intercostal arteries, and this is the posterior intercostal artery. So normally if the heart is alright, there are all these collaterals over here that connects to the anterior and to the posterior towards rib 1 until 12. So in the first two ribs is fine, but when we're talking about the coarctation, when there's coarctation, very little bit, the pressure over here is lesser compared to these anterior intercostal arteries. So the pressure here is higher. So this causes the blood to flow more towards this side, towards the posterior end, and the pressure over here is little, so it can't really like flow back this way. So therefore there is rib notching. So here the arteries will pulse, and have rib notching. Literally rubs against the ribs. So in a chest X-ray, we can see the ribs over here, these normal ribs, right? The rib notching will look something like this, like it got eaten a little bit. So this is the ribs. So this is how the chest X-ray look like for the kids. Now for the ECG, we know that there is left ventricular hypertrophy in the beginning, right? So we see left ventricular hypertrophy changes. So what are they? Dominant R waves at V5 and V6, and also deep S waves in V1 to V2. So dominant R waves, I would look at dominant R waves is long and big and huge. The S would be something like deep over here. Echocardiogram, to see the chambers, sorry, to see the extent and also the anatomy, is to assess the anatomy and also to assess the blood flow pattern and also the coarc size. Yeah. So now lastly we come to treatment. Oh, sorry, I do not have enough space. So in critical care and when non-critical. So in critical phase, normally it's in newborns. You want to think about to maintain the adequate perfusion of the lower body, because by using the ductus arteriosus, because it might be too severe over here. So you want to think about quickly resuscitating the child by using inotropes, mechanical ventilation. IV prostaglandin is important. PGE is good to maintain the ductus arteriosus for a while, because normally it would start to close within a few days, like 2 days or 3. And once the patient is stable, you want to push in for surgical repair. So how it look like is resection for end and also end-to-end anastomosis. Basically just cut this out and just sambung it balik. And also you can do a subclavian flap as well, clavian flap, where you just cut out a flap from the subclavian artery over here and also just remodel it in that way. So for non-critical cases, we can do balloon angioplasty or also the surgical repair as well. So it really depends on the pediatric cardiologist and also depends on the condition of the child. So that's all we have for coarctation of aorta. Hope it helps. Thank you.